man. And she was constantly drinking carbonated drinks. Yeah. Did you find that your weight was constantly fluctuating when she lost it?
Okay, it still kind of does.
It still does, yeah. Same thing with her. It's like it doesn't matter what she eats, it goes up and down.
Yeah.
It just goes up and down, yeah. Okay, any questions here? All right, so pathological indications for an OCG. What an OCG stands for, original gangsta. OCG, oral cholecystogram. Oral cholecystogram. It is a study of the gallbladder. Oral is in there because what that means is that the patient the night before is going to be taking pills that have barium or iodine. It's contrast pills. So when they take those pills, the contrast will eventually make its way into the gallbladder. So they come the next day and we'll start taking pictures of the gallbladder. But like I said, not common now, but they still do it. Now gallbladders are evaluated through either CT or ultrasound.
What would happen though if like a patient had like an allergic reaction to that at their house? Is that under any supervision?
Okay, that's actually a very good question. What they had found out was that iodine reactions usually, if you're talking about a major iodine reaction, it's usually vascular in nature.
Oh, okay.
So it has to enter your bloodstream in one form or another. In your book, it'll say iodine pills. In my slides, it says barium pills. Most common pills that they use is barium because of that reason. That there still may be a possibility that the iodine may leak into the vasculature, causing an iodine reaction. And that's why they have the doctor, not you, the doctor has to do a very, very thorough history on that patient before they prescribe them those type of pills. Okay? So there is no injection here, it's just they're popping it in their mouth the night before, and then the next day we'll start taking pictures of the gallbladder. Okay? So reasons why you would do an OCG, the first one here is, this is just basically an introduction to some of the terms. Okay? So the first term here is cholelithiasis, which is stones in the gallbladder. So cholelithiasis is stones in the gallbladder. The stones themselves are called choleliths. So stones in the gallbladder is cholelithiasis, and the stones themselves are called choleliths. You can't say these words if you have a lisp.
Right.
I was just thinking about that because I'm struggling right now. Cholecystitis. Cholecystitis. What's that?
Inflammation.
Inflammation. Okay, this is inflammation of what?
The gallbladder.
The gallbladder. Okay, so this inflammation of the gallbladder. Neoplasm is just a new growth. Hopefully it's not cancerous and benign, but they do that for any type of growth in the gallbladder. Stenosis.
Narrowing.
Okay, it could be a narrowing. It could be a stenosis caused by a blockage. So it could be a narrowing of the duct. It can be a blockage of the duct. Any type of congenital anomalies. And then cholelithiasis. Cholelithiasis means stones in the biliary ducts. So we talked about stones in the gallbladder. This is talking about stones in the ducts. That includes what? Remember the, where did it get, yeah, Darth Vader?
Vader.
Yeah. The ampulla of Vader. If it gets stuck in the ampulla of Vader, those stones is called a cholelithiasis. I think it's a quiz next week, right?
Mm-hmm.
Right. Spelling counts.
And we use our phones then, or?
Hey guys, I'm always serious, right? I'm being
Always.
serious right now. Okay. So the function of the digestive system, again, is to intake and digest food, absorb the necessary nutrients, and then the elimination of any type of product. It begins at the mouth with your teeth. The teeth and then your saliva. That is where it begins. Your teeth, the chewing, the mastication, That is part of mechanical digestion. Your oral cavity, the roof of your mouth, the roof of the mouth, you have a hard palate, which is anterior. You have your soft palate, which is interior. The portion of the soft palate that projects inferiorly at the very back, looks like a punching bag.
Uvula.
What is that called?
Uvula.
Is it uvula? My uvula? Uvula. Okay. The tongue aids in the mechanical digestion. And then we have the salivary glands. Again, you have your parotid, your sublingual, and your submaxillary that helps digest the foods through chemical digestion. All right. Within the oral cavity, actually it's just the upper part, your upper digestive part over here. You have the 7 cavities that communicate with the pharynx. Remember we said the pharynx is broken down into 3 different sections. You have your nasopharynx, which goes from the bony nasal septum to the soft palate. Oral pharynx goes from the soft palate to the epiglottis. And then your laryngopharynx goes from your epiglottis down to the level of C6. That's going to be your laryngopharynx. So you have 7 cavities, 1 and 2 tympanic cavities. What does the tympanic cavity do? I mean, what is it? What is the relationship there with that, with the oral cavity?
The
Bless
ears?
you? Was that a sneeze? Oh. Okay. So what is that cavity?
The ears?
You remember the eustachian tube? So that's the part that communicates with your ears. Okay. So we know that if you get an ear infection, it's a possibility that you can get a throat infection. If you get a throat infection, it's possible that you get an ear infection. Who has kids? That happens all the time, right? They got sick and they're pulling on their ears. Okay, nasal cavities, 3 and 4, bless you. Oral cavity, larynx, and then the esophagus are the other cavities that communicate with the pharynx. Please note, we talked about this last semester, but again, as a reminder, you have 2 pipes going down your neck and your chest, okay? Trachea is on the front, esophagus is towards the back. Okay, trachea towards the front, it's anterior, esophagus towards the back. Sorry. Give me just a second. Okay. All right, so the pharynx, again, broken into 3 different parts. It just replicates what we saw in the previous slide. Your nasopharynx, not part of the digestive system. That's the bony nasal septum, all the way back to the nasal cavities and, nasal septum cavities and to the soft palate. The oropharynx is from the soft palate to the epiglottis, and then the laryngopharynx, also known as the hypopharynx. Know both terms, because it's another term for laryngopharynx, is hypopharynx. Okay, it's the epiglottis down to where the larynx is located at the level of C6. So what happens at C6?
The trachea begins.
Okay, not the trachea. Okay, we're talking about the digestive system. So what is it? So what starts there? The esophagus. Okay, so at C6 is where the esophagus starts. Okay. So, do we all know where C6 is? You guys know where C7 is?
Yes.
Okay, so we know the vertebral prominence of C7, right? So C6 is just slightly above that. So, kind of where the angle of your jaw is, okay, Adam's apple level, angle of your jaw is where the esophagus starts. So when we do an esophagram, we are looking at your esophagus from here to here. I don't want to look at your mouth. I want to look at the esophagus from here to here, starting at the level of C6. So when positioning your image receptor for an esophagram, you see a lot of technologists having the top of their image receptor up to here. That's wrong. It should be down here somewhere. Now, are you going to correct them?
No.
No? Okay, good. Because this up here is not part of my digestive system. Unless you can swallow with your nose. Okay. There it is.
I got it.
Yeah.
I spelled it right.
I know. I just happened to be looking at you. I wasn't implying anything. I just happened to be looking your way. Okay. Deglutition, active swallowing. So in the act of swallowing, the soft palate closes off the nasopharynx. Okay. So when you're swallowing, there is a valve up there to prevent any food from going where?
Up the nose.
Up your nose. Okay. But some people have a talent to control that. Yeah. You one of them? You can do that?
I can do it.
Really? Extra credit.
Yeah, you pull the bar.
Really?
Yeah, it's my whole family. Like, I don't know, it's genetic.
She comes from a long line of
Uh-huh.
How do you figure that out?
nasal controllers.
There's all stuff connected.
Oh, that's cool. Okay. All right. Sometimes it happens from.
Oh, yes,
Doing that
I
too much,
also have
yeah.
a drug problem.
Yeah. All right. So when you swallow, nasopharynx is shut, and then
It's a
your
self-induced
epiglottis
talent.
covers.
Yeah, I work
What's the
really hard.
epiglottis covering?
Trachea.
The trachea. Okay, because now we don't want any contents to go into the lungs. Okay. So soft palate closes the nasopharynx, epiglottis covers the trachea, the laryngeal opening. All right? The esophagus is a muscular canal approximately 10 inches average, and it begins at the level of C6. So again, we know where C7 is. Now we know where C6 is, right?
Mhm.
So it begins at the level of C6 and terminates at the stomach. It is posterior to the trachea, so the esophagus is between the trachea and your vertebral column. It is the narrowest portion of the digestive system, and it pierces. Okay, this may be a question. It pierces the diaphragm at the level of T10. The esophagus pierces the diaphragm at the level of T10. Does it stop at T10? No, it's continuous. It goes through the diaphragm and it's continuous. And now there's going to be a small portion of the esophagus right below the diaphragm before it connects to the stomach. That's known as the cardiac antrum. Okay, just write that down for now. I have it here somewhere. But that small portion of the esophagus right past the diaphragm as it connects to the stomach is known as the cardiac antrum. Okay. This is a new slide. What's all this about? Esophagus relationships. Okay, so the esophagus extends from the level of, we said C6 all the way down to T11, and it pierces the diaphragm at the level of T10. Yes? So your esophagus starts off here, ends here at T10 is where the esophagus pierces the diaphragm. Okay. The esophagus is between the trachea and your spinal column. And yeah, that's all we need to know. Now, when you're doing an esophagram, it is a semi-thick pipe that goes down the chest. And it should be nice and smooth and consistent on all sides. However, there are going to be a couple of indentations, and sometimes they can be mistaken for a blockage or some sort of anomaly. Now, these indentations are caused by the aortic arch. That's the first one there. So you will see that it's nice and smooth, and then all of a sudden you see a little indentation being caused by the aortic arch. Do you guys also know this is a reason why sometimes it's hard to drink something or swallow something when your heart's racing really, really fast? Or you get that little pressure on your chest? Has that ever happened to you? Like when you're drinking when you're working out, you feel that little pressure. That's because it's trying to go through this area right here. Okay? And then the second indentation is caused by the left primary bronchus of what structure? When you say bronchus, what are we talking about?
Trachea.
The lungs, okay? So it's going to be the left primary bronchus of the left lung. Okay, good. All right, we have the hard dilation of the esophagus. Okay, So it pierces the diaphragm at the level of T10. Okay. Diaphragmatic openings. So we're talking about here the openings in the diaphragm. One is the esophagus. The other structure, the two other structures, bless you, that are going to pierce the diaphragm includes the vena cava and then the aorta, bless you.
Thank you.
So here's the cardiac antrum. The cardiac antrum is a portion of the esophagus between the diaphragm and the stomach, and it's generally 1 to 2 centimeters in length. Okay, so that's the cardiac antrum. All right, this slide depicts two perspectives. One is looking from the bottom up. So we have the inferior vena cava here on the right side. We have the aorta down the middle, and then the esophagus right off to the middle, around the same area as where the esophagus enters and the aorta enters. This is especially important when you guys are looking at CTs. When you're looking at CTs, because some of you have already been in CT, knowing the difference between where the vena cava and the aorta is. The vena cava, because they look both the same, the aorta look the same, they're both round, they're both big, but the vena cava is going to be on the right side, aorta is going to be on the left side. So that's how you differentiate the two. Okay? All right, stomach anatomy. Now let's talk about the stomach. This portion here, this is the portion from the diaphragm to where it joins up with the stomach. What is that portion called?
Antrum.
Okay, that's the cardiac antrum. Okay, so that's the most distal part of the esophagus in relation to the stomach. The stomach's broken up into 3 different parts as well. The most superior portion of the stomach is known as the fundus. We've heard that before? We were talking about the gallbladder, right? Okay, so we have the fundus. What's next?
The body.
The body. Now, the most distal part of the stomach is known as the pyloric portion. The pyloric portion. This is the entire pyloric portion. And now the pyloric portion is broken up into 3 more parts. As the content enters the first part of the pyloric portion, this is the pyloric antrum. The second part is the pyloric canal. And then lastly is the pyloric orifice, but it's most commonly known as the pylorus. Now, what do you think is going to happen here? What is it going to communicate with next?
Duodenum.
Okay, the duodenum, the duodenum, the proximal portion of the small intestine, right? So this is where it's going to enter, right about here. All right, so we've got the fundus, we've got the body, we've got the pyloric portion. 3 main parts. Other parts or areas of the stomach that you need to know. The stomach has 2 curvatures. It has an outer curvature, it has an inner curvature. This is the larger one, so it's called the greater curvature. And this is a smaller one, so this is the lesser curvature. Okay? Greater is on the lateral side. Lesser is in the medial side. Okay. And then you have your notches here, where the esophagus meets with the stomach. This is known as the cardiac notch. This area here of where the body turns into the pyloric portion is known as the angular notch. The stomach is the most dilated portion of the alimentary canal. It is a reservoir for food and fluid. Within the stomach, you have foldings of the inner lining. Within the stomach, you have folds. These folds are called rugae. Okay, rouge is plural. Ruga is singular. Rouge and ruga.
Very bougie.
So here's a picture of the rouget. Okay? So, again, the stomach has these inner folds. The whole purpose of that is it allows the stomach to expand and contract. Okay, that's the purpose of those linings. Okay, expand and contract. It allows that. Towards the lesser curvature, you're going to find this opening here. It has rouget, but not as much. But it is a direct connection from the esophagus into the pyloric end. This is known as the gastric canal. So this particular canal allows passage for fluids. So if you're drinking a soda, okay, drinking water, notice that when you're drinking alcoholic beverage, all of a sudden it hits you because it's going straight through the gastric canal and into your brain. You guys didn't get that, right?
Brain?
It does, yeah. It goes straight into your system. Your intestines absorb it, and it goes straight into your vasculature and your brain. Okay. All right. Let's focus down here for a moment. 3 divisions of the stomach. Okay, we said it was the fundus, the body, also known as the corpus, and then the pyloric portion. The position, the anatomy, position, and orientation of the stomach, you need to know. You must know. Because when we're looking at an upper GI is a study of the esophagus as well as the stomach. When you're doing an upper GI study, knowing where the contrast is in relation to the air in the stomach, because you know you have air in your stomach, right? So the relationship between the contrast that was ingested with the air will tell you what position your patient is in. Just by simply looking at a radiograph, you know exactly what the position the patient is in by looking at where the contrast in the air is. Okay? So the fundus is going to be more posterior. The body is going to go from posterior, from your back towards the front, and then the pylorus is going to go from the front to the back. Okay? So here is an AP projection or AP view. The stomach has a J shape to it. Doesn't tell you much about orientation, but when you look at the lateral view of it, here is the fundus. Remember, we said the fundus is posterior. The body starts to make its way to the front, from the back to the front, and then when it reaches the pyloric section, it's going from front to back. Okay? So, if the patient is on their back, okay, heavy material is going to go down, light material like air is going to go up. So if they're laying down, because we said the fundus is towards the back, the barium is going to sit on the fundus, while air rises to the body in the pyloric portion. Everybody got that?
Why
Yes.
would it also go to the back of the pyloric portion?
I'm sorry, one more time?
Why wouldn't it also go to the back of the pyloric portion if that's also
Which image are we talking about here?
supine?
Supine over here. Why wouldn't it also go to the pyloric portion?
If it's also posterior, which is on
Is
supine.
it supposed to be a fundus there, the heavy?
I feel like
Oh, you mean like over here? So, again, we're talking about average sized patients, okay? So it can't, sometimes you may see it there, sometimes you won't. It also has to do with body habitus. What we're looking at here is now just the average type of patient. So based on your body habitus, remember, if you are big, it's going to push everything up inside, up into the side, which also means that it's not only going up, but also may push it forward or backward. Same thing with if you're aesthetic. Now it's lower, everything may get pushed back, and instead of looking like from here to here, it's just going to be straight flat. So this is just your average type of patient. Average physiology, I should say. But the scenario that you have given, it can happen. It's possible. Yeah. All right. So now if you're prone, you're face down, because the body, okay, the majority of the body and parts of the pyloric portion is anterior, that's where the barium is going to go now. Okay, you're laying flat, and now this is on the upside, so air is going to go towards the back. Okay, and then naturally, well, what's the difference between this one and this one? They kind of look alike. Because it says here this is upright. What's the difference between the two?
Even.
Exactly, you got the fluid level. This here is telling you this is the fluid level. They're upright. You guys got that? Does that make sense? This is the fluid level right here. This is telling me the patient is in upright position. All right, how we doing? I know, right? All right, the duodenum. This is going to be the first part. So this is where we're going to end this part of the upper GI, is the discussion of the duodenum. We'll talk about the second segment and third segment in our next lecture. So the duodenum, because this is included in the upper GI. So from the stomach, the pyloric orifice, the pylorus is going to communicate with the proximal portion of the small intestine, that's the duodenum. So it's the first portion of the small bowel. It's 8 to 6 inches in length.
8 to 6.
What happened?
You said 8 to 6.
I know I did right. 8 to 10 inches. It's not about the size. Come on.
Always.
You walk into that one, dude.
I know I did.
Yeah.
All right. 8 to 10 inches in length. It is the shortest, widest, and fixed. It's fixed in an area at the most distal part of the duodenum. It is going to be held up and together by the ligament of Treats. And I'll show you a picture of that later on. The duodenum forms a C shape. Okay, forms a tightly curved C shape. And then I will show you its relationship with the pancreas. Okay, because they have a relationship. And this relationship is called the romance of the abdomen.
I think I've seen that movie.
I didn't make this up. Romancing the stone. Romance of the stone, okay. I knew it sounded familiar. So romance of the abdomen, and it is considered a retroperitoneal structure. So does that mean it's within the peritoneum?
Mm-mm.
Did we talk about the peritoneum before?
Mhm.
The lining
It's behind it.
of the abdominal cavity, so it's not in the peritoneum, so it's behind it. Okay, so it's a retroperitoneal structure. All right, so the duodenum has 4 areas: the superior portion, descending, horizontal, and then ascending portion. Looks like this. So here we have the pyloric portion of the stomach communicating with the duodenum. The first portion of the duodenum is known as the cap or the bulb. The duodenal, bless you, bulb or cap. So that's the first portion. So this is the most superior portion. Now it's going to descend. Okay. This is the area where it receives the common bile and also the pancreatic ducts. Now it's going to go horizontally. That's your horizontal portion, and then makes its way up, ascending. This portion of the duodenum, that loop, is held by the ligament of Treats. The next portion of the small intestine will be the jejunum. We'll cover that later on. Okay? Now see the C? Okay?
Mm-hmm.
That's the C. Here's the head of the pancreas. Romance of the abdomen.
Romantic.
They're very romantic, yes. That's
Spoon.
why they call it the
I was
romance.
gonna say
They're spooning. The duodenum is a big spoon.
All right, enough of that. All right. how is food digested? Okay, the first one here is through. What happened?
You said food, so she got excited.
Are you guys ready for a break?
Can I eat?
Yeah. Okay. The reason why I'm asking is I see a lot of yawning. I also see some people falling asleep, which is, I mean, this is.